and thank you for having me for this meeting again. I was honored to be able to talk last year about our initial few years experience with hyperthermia in Hungary. My name is Marcell Szasz. I'm a fellow in medical oncology at Semmelweis University. I also am a pathologist, and you will see later why this might be important. This year, I'm happy to present you a prospective randomized clinical trial, which we have started about a year ago for breast cancer patients. And this is an important milestone for us because we were mainly treating patients with advanced disease. And this is the first time that we turned to the early breast cancer cases, especially to those who are being treated before surgery. So in Hungary, as you might know, it's a small size country, but we are in between East and West. And we have a problem with cancer that we will have a double occurrence, or incidence will double in the next 10 years, probably. This is expected by the WHO for globally, but sadly, we tend to have this probably in 10 years. So there is an increased need for treatments and to have a better treatment for the patients, and most of all, to have preventive methods. So our aim is to cure more women in the early phase through this trial and through this method, and have more people alive with a good life quality. So these are the numbers in the world what's being expected by the WHO, and the cancer will increase all over the globe as they expect. This is partly due to better diagnostics and improved diagnostic capabilities, but also the aging population and the increased population, not to mention the pollution that we have put on the earth. So we would like to overcome these inefficiencies which we face, especially here in this region, with the diagnostics and treatment modalities. So while our challenge is just mentioned early detection, we have to find better and more curative treatment methods. And of course, with curing more patients, we see that we have to have an efficient follow-up and reintegration into society with an improved quality of life. So this is really a challenge to find the optimal treatment. I don't think we have found any optimal treatment so far in oncology, but we still specify our subspecialties into surgical, radiation, and medical subspecialties. But there are the fourth ancillary techniques where we intend to use other methods like radiofrequency, electromagnetic, or thermal methods. It's challenging for the society, of course. There is a burden because we have more patients alive and we have more questions to answer. We have to provide them information in order to be able to reintegrate them into society with an improved quality of life. So we have to have transparency in our clinical trials, so we have better cooperation by the patients. And this is done through communication. And there is a tech industry which is supporting us, actually, that we have more methods and more techniques and more devices that we can use. Of course, cybersecurity and other supplies for clinical trials are there now. So we have a much easier work, I think, in some ways, and we can do improve the clinical trials, especially in our world we can also analyze retrospective data, which we are now fancy calling real-world data and self-reported outcomes. So I don't think I have to dig deep here at this forum, but I thought I will just mention our device, which we have at our oncology at Semmelweis University. So we have 2 beds of oncothermic device, also known as modulated electrohyperthermia, which is actually an interesting method. And we have now this year 2 Nobel laureates, Katalin Karikó and for her work in COVID vaccines, and also Dr. Krauss in his work in physics in laser science. Szent-Györgyi Albert was also a Nobel Prize winner in Hungary for discovering and describing vitamin C. And then he moved to Massachusetts in the US, and he worked on electric fields and their effect on cancer, actually. So this effect that cancer is actually more conductive towards electricity. Thus, modulated electrohyperthermia is an efficient method to treat them, is actually started by this gentleman. We have actually, when we started 8-10 years ago to work with hyperthermia, we of course wanted to see how the science stands, and because we are traditional medical oncologists and medical doctors, we aimed at supporting others, and took the literature and made a review on the clinical evidences in which tumor type where we stand with modulated electrohyperthermia. And we see now that there are multiple clinical trials and lots of experience and evidence gained that we use it more and more in our practice. And we were also able to publish the guidelines for local hyperthermia in oncology, especially regarding modulated electrohyperthermia. So, as mentioned, we had the palliative cases when we had no options, and for multiple tumors, especially when we had no other option for the patients. For instance, we offered this treatment as monotherapy, or if we could do that, we combined it with traditional oncological treatments. I will show you just some palliative cases, and mostly trying to focus on breast cancer, where this case was a liver metastasis, which was treated by hyperthermia in line with immunotherapy and cisplatin and 5-FU. And with a few treatments, there was a dramatic response. And this is also from Asia. A report from a patient with breast cancer. Similarly, in breast cancer, but another metastasis in the brain, and this could be treated also with hyperthermia, and there was a good response to this therapy as well. It's strikingly shrinking the metastatic lesions in the brain, and the patient had a good outcome. So instead of, we always get the criticism, also in Hungary, and probably in the international oncological societies, that there are not enough evidences to provide these treatments to our patients. So we went on to have instead of having retrospective and single-arm analysis or historic or matched controls and various tumor types, we went on to treat single cohorts. So we started with a mixed cohort, but then we had a lot of GI cases and breast cancer. So we designed a trial for pancreas, a prospective randomized trial for the first line, metastatic setting And we couldn't do this anymore because we had established at the University a pancreatic center, so they are being treated somewhere else. But on the other hand, we have the breast cases, so we designed this prospective randomized controlled trial in breast cancer. And as time flies by or passes, we have an improved understanding, at least we hope. We do understand a little bit more of tumor biology, not including hyperthermia, but other factors, the immune tumor interface. And with tumor markers, we can see much better into the processes, and we can have better predictive factors. Of course, another Nobel Prize phenomenon was that we discovered the immunotherapies in cancer. And if you look at this map with the various cancer types, we can see that breast cancer, regarding these immune cells, it shows a very mixed population, but an improved chance to interfere with them, along with colorectal cancer as well. There are various attempts and various markers. This shows how the immune environment, actually from macrophages to T cells, from natural killers to helper cells, how they actually behave and how they interfere with any kind of therapy we give. It has actually an imprint in our immune system repertoire, and there is an interface and communication between them. So we thought we will pull out an early phase trial for early breast cancer to cure more patients, and we would like to see the result in a short-term setting. So we don't want to wait for years, and we don't want to treat palliative cases anymore. We went on to the early stage. I will show you how. We already had results from stage 2 and 3 cervical cancer from South Africa, where a phase 3 randomized controlled trial was performed by Dr. Minar and colleagues. And they had an excellent prognosis and an excellent outcome, also in HIV positive and negative cancer cases there. So as mentioned, I'm a pathologist, so the idea came by that if we evaluate breast samples under the microscope, especially after treatment, we see in the microscope how the treatment affected the tumor, and we are really happy if we can report that the tumor was resolved, and by the time we have the surgery and the pathological examination, after a few weeks of treatment, we have a complete response. So this gave the idea to design shorter trials, and especially in breast cancer, where we have the neoadjuvant therapy, so we have a therapy before the operation. And triple negative breast cancers and HER2 positive breast cancers, which are the known or traditional hormone receptor negative cases, are being treated in Hungary with such treatments. And a proportion of the triple negative cases belong to the BRCA mutated cancers, where it has already been described and discovered that this pathological complete response was observed actually 9 out of 10 patients in this initial trial. The 10th patient didn't finish actually the treatment. So all 9 patients who finished treatment had a pathologic complete response to platinum agent in monotherapy. And then came by a few years ago another paper or another investigation from Germany, and they used hyperthermia actually to the patients who, after neoadjuvant setting, did not have a complete response. And they actually speculated over or suggested that this method or the hyperthermia induces BRCA-ness. So this type of defect, which is nucleic excision repair or homologous recombination insufficiency, which means, to put it short, that they will respond to cisplatin in a much better way because of the defect this gene alteration is causing. And they suggested that with hyperthermia, we can stimulate, or we can actually cause a heat-induced such a defect in the DNA repair mechanism. So we thought together with my colleagues that if we can use hyperthermia to make the breast cancer more vulnerable to platinum-based chemotherapy, especially in the early phase and neoadjuvant setting, we might get more patients who get a complete pathological response. So we looked at these the trials, what they did, and actually the Keynote 522 was an immunotherapy trial designed in the same way. So we used actually the template of this trial, which actually used the I-SPY2 template, which is a neoadjuvant setting trial for breast cancer. So we use the method that we use cisplatin and paclitaxel for 12 weeks. Actually, we give the taxane weekly, and now we also give the platinum weekly. So during these first 12 weeks, we give the hyperthermia 3 times a week. So we have these 12 weeks of treatment, which is being followed by another cycle, which is the AC, anthracycline and cyclophosphamide, which we give every 3 weeks then. So this was the trial design. So that's why we follow this design together with the trial design of the immunotherapy trial. We have core biopsy and regular blood samples all over, spanning over this treatment. And then we evaluate the specimen after 24 weeks. So it spans over about 6 months, and it's a relatively short trial. And as we know, pathological complete response is the best prognostic factor for the patients to survive the longest. So that's what we aim for in our triple-negative breast cancer cohort. Actually, we also treat non-triple-negative breast cancer cases, and now that we know from recent trials that presented at ESMO, also luminal breast cancers are responding to immunotherapies up front. So we have the same design without the platinum, and we will see whether this heat-induced BRCAness or other factors will improve pathological complete response in other breast cancer cases. So we plan to enroll 120 patients. We are now at 21. So I hope to present you more results in the near future, because at day 2 of our patients have completed the neoadjuvant treatment, and both have had a clinical or radiological complete response before surgery, and we are awaiting right now for the histology. So, and we had to move our cancer center during the year, so that is why we are a little bit in a backlog, and we have to have more patients enrolled in the near future. So I hope you enjoy this. I think for me, it's a very exciting clinical trial, and I look very much forward to this, to the therapies. This is how we see it and how we look at it. There is a span over radiotherapy, chemotherapy, and targeted therapies. I think hyperthermia will be the next history-changing method in oncology. Thank you for your attention.